Okay, normal heartbeat starts in the sinus node, the SA node, and it follows that pathway there in red. So the sinus node through the internodal pathways, making that little hop over to the left atria also, which doesn't really show on there, but we depolarize down here when it also hops over to the other side. And then down into the AV node, the bundle of His, left and right bundle branches, Purkinje fibers, and all that. So the regular sinus rhythm, and just so we're all clear, the rhythms you will look at for the next however many days we do this are all lead 2 rhythms. So lead 2 being the one that looks the closest at that conduction pathway from the SA as it goes straight down, all the way down the septum. So we're going to have a positive upright P wave, which will be before every QRS complex. So that's one of the characteristics. P waves should look alike. We're going to have a constant PR interval and a regular atrial and ventricular rhythm. Now, like all our rhythms, and this slide's going to come up again, whether it's junctional, whether it's whatever the rhythm is, actually this will affect the sinus rhythm, so maybe one of those other rhythms actually takes over. But we will see this quite often, what affects our different heartbeats, or our heartbeats. Medications, diseases that affect all kinds of things. How many patients do we see daily that are on one or more medications? Just about all of them, right? In fact, when you see that one that isn't, when you find that 85-year-old and you say, you take any medications, and they take vitamin D and, you know, something over the counter, and you're like, that's it? Usually it's a whole, here comes the shopping basket. So it's our normal heartbeat. Sinus rhythm it reflects normal electrical activity. Again, same picture we just saw. The SA node fires faster than any other part of the conduction system. What's the rate of the SA node supposed to be? 60 to 100. And then we go down, we hit the junction, AV junction, and that would be 40 to 60, and then below that, 20 to 40. That's either called the ventricular rate or from the Purkinje. Yeah. So normal heart rates by age. This kind of information is stuff that, for me personally, going through as a paramedic and learning this stuff, there's so much to learn that some things in my mind have to take a backseat to others, and this was one of those things that kind of took a backseat. And the reason I went this way, was really fortunate. When I was in paramedic school, the paramedic I worked with was one of Valley Fire's very first paramedics. And we had a walk-in patient, little kid, who was actually doing a tour. They were out in the bay doing a tour, and the engineer and the other firefighter out there doing the tour, and he was in there to help do it. I think I just got back from paramedic school, from class actually. And the kid, you know, the usual, get in one side of the engine, sit down, and do it, and then come out the other. On his way out the other side of the engine, he took a header out of the engine and crashed. And so, of course, the engineer pawns him off on us, and the kid's crying, and we take all his vital signs, and Terry, the paramedic, goes, well, what were his vital signs? And I told him, and he reaches in his job shirt and pulls out the little EMS, the little blue spiral-bound guide, flips to the pediatric page, looks at the kid's age, and goes, yeah, they're in normal range. And I'm like, what'd you just do there? So here he is, a 30-year medic, and he's using a reference sheet. Because in my mind at that time, we had to know it all, right? We couldn't use any reference sheet. So don't be afraid to use things like that, Broslow tape, that kind of stuff. So this is the kind of stuff, yes, right now, you might want to lock it in there for that test in January. But I think there's so much information that something kind of has to go a little bit, and this might be one of those things. So this is the stuff we really have to get down, is this, how do we recognize the rhythm? And it's this using the rate, the rhythm, regularity, P wave. Have a system set up. This reference sheet we gave you yesterday, it has, what is it, 1, 2, 3, 5 steps to look at. Might be a little different than the ones up here, but it's, you know, kind of has the same characteristics. Find a way so that you always go down that same, especially now. Because what ends up happening now in the field, if I see something that looks goofy, and I can't really, by glancing at it, look at it and see what it is, and I go back through this little check. Is there a P wave in front of every QRS? Is it regular? What's the rate? So sinus rhythm, by definition, the rate has to be 60 to 100. We're going to have a regular P to P interval. So remember, that means if we take our calipers, we measure from the same spot on 2 different P waves, we should be able to flip it over to that third and that fourth, and it should just march out. And the same with something on our QRS complex. You guys got calipers yesterday, so were you able to, did you get to play with them at all and use them on anything? No, you just got them? Okay, today we'll get to use them. Hopefully you have them. P waves, positive, upright. And we're looking at lead rhythm, so everything will be in lead 2. 1 P wave with a QRS. So think of them as husband and wife, boyfriend and girlfriend or something. The P wave and the QRS, they're always together. The PR interval, these are the numbers. This number is important. 0.12 to 0.20 seconds, constant from beat to beat. So if the first beat has a PR interval of 0.12, then the next one will be 0.12 also. You're not going to have one beat that's 0.12 and the next one 0.16 and the third one 0.20. For that rhythm, they should all be the same. You will see a rhythm where that PR interval will change when we get back from break. So for a sinus rhythm, we have to have that same PR interval has to be constant for one complex to the next to the next. And the QRS, this book says 0.10 seconds. I always remember that as 0.12 or less, unless a conduction delay exists. What's that? And this book says 0.11, right? So you know what I would do to be safe is put 0.10 to 0.12. That's how I'd remember it. And I think Gary will give you either. What's that? So in our book we have 0.11 and 0.12. Awesome. Yeah. So there it is. There's all the characteristics, and that's what I would really try to get hammered down in my brain are those things.
The QRS duration, that's just the QRS, right?
Mm-hmm.
So I thought you said a normal one is about 2 to 3 boxes. That would be
little boxes.
Oh, little boxes.
Little boxes.
Right. So 1 box is 0.04.
04.
Okay. That's good.
Yep. So here's what I'd like to do right now. Why don't we? Oops. So by definition, what's bradycardia? 60 and below. So of all our other characteristics, let's make this really simple here. All our other characteristics for sinus rhythm are going to be what that we just saw on this previous slide in a bradycardic rhythm. What would be different? Let me see if we can do this. Okay, of those 5 things, 6 things, 5 things. I need Christmas break too. Of those 5 things, that's the normal sinus rhythm, 60 to 100. What do you think would be different if it's sinus Brady? The rate. And the rate's going to be less than 60. And if it's sinus TAC, the rate's going to be greater than 100. What about those other 4 things? Are they going to change? No. Perfect. Let's stop right there. We're going to do some practice. Okay. So sinus Brady. Let's talk about that here for a little bit. And then we'll go until about 1:15, and we'll take a little break. So what causes sinus brady? And this is where we get calls on this to our adult family homes and places like that with bradycardia and low blood pressure and all that. Sometimes it's very, benign too. It occurs in adults and children while sleeping. So it's not uncommon for good old Engine 7 to go to one of our local assisted livings or adult family homes for a bradycardic patient who's in bed. And they go and they slap the little pulse ox heart rate monitor thing on him every hour or 2 hours or 4 hours or whatever their rounds are. And they say, oh my God, this patient, their heart's slow, their blood pressure's low, and they're asleep. And what's that?
They're unconscious.
They're unconscious because, just shake them and say, hey, wake up. Now they're not unconscious. Well-conditioned athletes, so there's the other one. That's where you have to treat your patient and not your numbers. So well-conditioned athletes could be down in the 40s. Present up to 35% of people under 25 years of age while at rest. So many of us, some of you in this room or maybe hit that age group. I know I shot past that a long time ago. But while you're resting would be sinus brady. What else do you think causes it? This is one that may or may not surprise you. Common dysrhythmia associated with acute MI, often seen in the inferior, so the bottom of the heart. So the 2, 3, and AVF. So you have that bradycardic patient that's not feeling well, even if it's not chest pain or it's not feeling well, the 12 lead is probably your go-to move there. Okay, some causes of bradycardia. So vagal stimulation, coughing, vomiting, straining to have a BM, sudden exposure of the face to cold water, carotid sinus pressure, so some other things that can cause that. Another common reason we see these patients, the straining to have a BM, they'll brady down to the point where they'll pass out. By the time we see them, they've come around and they're actually asymptomatic. So when you have your SVT patients and you're trying vagal, maneuvers, when you see the list up there, really that's on the list. There is, in our county's protocols, there is the carotid sinus massage. You can do that. There's the bearing down, so the straining. With children, you can put their face in, stick them in ice water. And as you can see, we have a whole slew of causes. So when you think about who our customer base is, we look at the medications, and we look at some of these other things, it wouldn't be uncommon for us to have a lot of patients that would be in, bradycardia. So what would be a good history question to ask them? Medications. You have a pacemaker. Any heart history. What's your pulse? What's it normally run? Some other signs and symptoms. So they're hemodynamically compromised. So then we're going to start having our chest pain, shortness of breath, signs of shock, which would include low blood pressure, altered mental status, a cold, clammy skin. So what do we do about it? Well, maybe nothing. If it's not symptomatic. If we came around the room here and took everyone's pulse and found one of you guys or gals that was sitting here at 50 beats a minute, we're not going to throw atropine at you just because you're sitting here at 45 beats a minute. But if symptomatic, there's our pretty much our treatment there: oxygen IV, atropine, and if atropine doesn't work or very severe case, we could pace that patient. Remember, that's got to be with symptoms, though. You guys had atropine as one of your medications yet? Is it? I saw a list. Is that today or this month, or was it a couple weeks ago? What's your dose? 0.5? What about pediatric? 0.02. So atropine, we won't cover that since you guys have already had that as a medication. Let's take our break right now. Sinus tach. So our sinus nodes firing faster than normal for the patient's age. So that makes sinus tachycardia. It may begin or end gradually. Looks like sinus rhythm only faster. And the reason I wanted to kind of cover these slides, and because I know we said, okay, if it's over 100, it's still sinus, but a couple of little good key points here. It may be hard to tell the difference between a P wave and a T wave because they're going to be right up to each other, or they actually might, if it gets really fast, they're going to be kind of together. You don't know if it's a P or a T. QT interval normally shortens as the heart rate increases. So remember that QT interval, the start of the Q, QRS, to the end of the T, so that heart rate goes faster, that's going to get narrower. So sinus tach in adults, we would call that anything above 100, up to, and this slide says 180, but where in the field where we start getting panicky is that we're usually that 150 mark. That's where you see people start talking about medications, cardioversions, that kind of stuff, that over 150. In infants, it's a lot faster than that. Could be as much as 200. So how do we recognize it? So again, a rate over 100. We're going to see regular P to P and R to R intervals again.
Is there an instance where we can have the PT interval be regular, but the RR interval be irregular? Or are they always going to be regular? It seems to me that the PT interval is regular and the R and R.
For a sinus rhythm, they will always be regular. There are some other rhythms where we will get some variance in those things. Yes?
Question for you in regards to the time movement for all three of these. Why is the interval not changing if it's more rapid? Because that's the contraction. You said the QRS is going to shrink.
The QT is going to shrink. The QT duration will shrink. Okay. It's going faster.
So I'm saying after the measurements here, it's still saying the QRS is going to be less than 0.12. If it's that part, it should be automatic because it's going to be firing off a lot faster. Maybe it's not even.
Right, but we'll see when we get into the ventricular rhythms. We'll get some wide ones that go really fast, but they're knocked right up against each other pretty much. So you don't really have T waves or P waves. You just get what looks like just triangles, essentially. So and we'll see those as we get going here. So our PR interval, our QRS durations are the same. Let's not worry about the ST segment depression. I love that when they're giving you the very first example of a rhythm and they throw a nice little slider or curveball at you there. So there it is by characteristics, and if we compare that to our sinus slide, everything would be the same except for the rate. And when we look at what causes it, all kinds of good stuff. Now, I wish we could put the bradycardia slide up next to it, because some of the things are the same. Acute MI comes to mind. It was slow now, or it can be fast too. Yeah, just your right. Right. No. No, just like bradycardia is not a bad thing necessarily, right. So this top sentence here, this bullet, is something I think we need to keep in mind for all our rhythms and really for paramedicine in general, is correcting underlying causes. We have this box, orange box in most of our cases, full of all these cool things we want to use. And many times all we have to do is find out what's causing the issue and remove that somehow. Could be removing somebody from the environment, getting them out of a cold environment into a warm environment, or vice versa. I remember having a patient with stabbing, tearing, chest and back pain, and in my mind I'm thinking, oh, this guy's having a AAA or something. He's got this. He's calling it tearing pain. It's tearing through him from front to back. He had on a back brace. We took the back brace off him, and this pain went away. So, yeah. But when he's describing the pain initially, he's like, oh, it's this tearing thing. And he started going to, listen to his lung, what is this? Well, I got this back brace. I had surgery. Okay, we take it off. And like, oh, it's better. Okay. All right. We don't always go on the smartest patients either. So one of our newer things that's been in paramedicine here the last year in the field is the whole sepsis protocol and sepsis recognition. And if we go back a slide here, and we look at fever on here, thinking sepsis, and why does my screen keep changing? So, sinus arrhythmia, big deep breath, because now we're going to change the game a little bit. And what we got is sinus. And bear with me, I lost my screen again. Okay, so the SA node fires irregularly. The resulting rhythm is a sinus arrhythmia. It can be a respiratory sinus arrhythmia or not. So we can have a respiratory sinus arrhythmia or a non-respiratory sinus arrhythmia. The rate still stays between 60 and 100. Or it can be a sinus bradyarrhythmia or a sinus tachyarrhythmia. That one rate that we looked at today where we saw it and then all of a sudden it sped up. If it kept doing that, speed up, and then maybe it slowed back down. We only had 6 seconds there, so we don't know what it did the rest of the time. But we had some little arrhythmia in there, a sinus arrhythmia, because we had 2 different rates going on there. So everything based on our characteristics and criteria for sinus arrhythmia or sinus rhythm stayed true. But we just have, as you can see, this part just from the eyeball test, these 5 complexes look to be the same, and then up we get here, we've got a little change. Does everybody see that? And then I don't know what happens after that. Maybe it stays slow, and that was the little blip on the screen, or maybe it speeds back up. So how do we calculate that rate? This has a rate of 54 to 88. So what they're using is probably the 300, the box test. And if you do it between these two, it's one rate. If you do it between those two, that's the other. So you've got between this rate and that rate. So it's caused by intrathoracic pressure change with respiration. Some older individuals, common after inferior MI, medications again, or increased intracranial pressure. What's increased intracranial pressure due to respiratory pattern? What's that? Makes it irregular. Yeah, so it makes it irregular. So back one. And it's not something we generally would treat.
I've never seen that.
What's that? The arrhythmia?
Usually usually AFib or
right.
Something like that. I personally never seen it.
Very rarely. Sometimes you'll see it if you're having someone, if you watch the monitor. I've seen it with some elderly while somebody else is listening to their lungs and having them taking a deep breath. You'll see that deep breath. You'll see the slow down and then they exhale. But not really very often. The SA block. Okay, also called the sinus exit block. So our sinus node what generates the impulse, but it gets blocked from leaving the SA node. So what we get is we lose our QRS complex completely. So when we first look at that, we might go, that's irregular, might be AFib. But when we start applying our other criteria and go, well, all our other complexes, we do have a P wave in front of the QRS complex. So just right here, for whatever reason, our SA node either didn't fire or it fired and the impulse didn't get out.
So if the SA fires and then nothing else happens, you flip on there, and that's what you'll be?
You may or may not, and I've never seen this that I'm aware of. That's that's one of our issues is we don't, if we put a halter on somebody that had thought they had an irregular heartbeat or whatever, we might catch these things, but we throw the monitor on somebody, we print a little strip and we hand it to the paramedic, and the monitor's over there running, but we're not really watching it, right? We don't sit there and look at it or run print the whole time. So we may or may not even see these, and that's the real issue with a lot of these rhythms we're going to come across in this book is some of those, I'll bet out of the 24 of us, counting myself, 1 or 2 of us will never see some of these things. I know there's some in there that I haven't seen. Not that I've, not been around that long, but.
So, Dave, I'm thinking if the atrial fire from the SA node going off, right, you have P wave,
Mm-hmm.
then it's blocked. How come you don't see a P wave and then with a long trip and then maybe the ventricle kicking in? That's it.
Well, and that impulse is just going somewhere.
It's blocked intermittently?
Yeah.
Okay.
Yeah. Well, you'll see we have some other blocks coming up where you're going to see P waves because the atria does get depolarized, but you see no QRS complex to go with it. So you're going to see that coming up. So we're going to see, once we get into these second and third degree blocks and some of these things, you're going to see P waves with no partner QRS with it. Yeah. So when, this is a skip a beat, yes.
You'd be able to feel that.
Maybe not one, but if you have this regularly, or if this happened, every so often to you, yeah, you could probably feel that. Or sometimes you feel that little flutter, and you could have this going on where the SA block occurs, and then you get an accessory pacer takes over, which produces in that space a PAC, a preatrial contraction, a PVC, or a PJC. So something, if that pause is long enough, is going to go. Another part of the heart is going to take over and produce a beat to fill that gap. I don't know if I've ever felt the skip a beat. I know I felt probably the PVC from working out too hard or something. So again, what causes it? Here's our friend, the heart attack again. Drugs. Congestive heart failure, we've seen that before. We saw that on sinus tach. Increased vagal tone, so you bear down. You can slow it down. When you have to go take a VO2 max test, you can help when you want to get your resting or your recovery rate down, you can bear down and probably do that to yourself. So again, what do we do about it? Most of the time, nothing. If it becomes something that is happening quite often or becomes a hemodynamic condition, then you're probably looking at getting a pacemaker. Sinus arrest. So a sinus impulse is just not generated. So again, no QRS complex. So the difference between this and the previous our SA block and our sinus arrest, the block should be a one beat where you'd expect that one beat to go in between, where the sinus arrest is more than one beat. You would expect to be in there. So a pause longer than. And what causes it? A lot of our same cast of characters. These two, we're just on the last slide with digitalis toxicity. That's a drug toxicity from digitalis is a calcium channel blocker. It's a cardiac medication for rate control, like rapid AFib. Patients will be on that. And it's also the foxglove. Foxglove, the plant.